Welcome to our panel, Addressing Disparities in Access to Advanced Cardiovascular Procedures like Transcatheter Aortic Valve Replacement, commonly known as TAVR. I'm joined today by Joy Spencer-Smith, an aortic stenosis patient advocate, Dr. Erin Horne, co-chair of the Association of Black Cardiologists Structural Heart Valve Disease Task Force, and DeChane Dorsey, executive director of AdvaMed et al. And my name is Dr. Deidre Washington, and I serve as the Director of Health Equity at AdvaMed. And I have the pleasure of being your moderator for today's panel. And I'll mention that this discussion is being recorded and will be shared shortly afterward. The Medicare analysis completed by AdvaMed found significant disparities in the utilization of TAVR between white patients and Black patients, as well as between non-dual eligible and dual eligible Medicare beneficiaries. And even after controlling for clinical factors, Black Medicare beneficiaries were 40% less likely to receive TAVR compared to their white counterparts. So today, we're going to discuss how these study findings can be used to advance conversations about health equity and valve disease with policymakers and stakeholders, as well as steps that providers, patients, and policymakers can take to close the gap in treatment. And as we get into our discussion, if you have any questions, feel free to post them using the Q&A function, and we'll get to them at the end of our discussion. So we'll get started by introducing our panel. First, Dr. Erin Horne. Dr. Horne is a structural and peripheral cardiologist who treats patients across the gambit of cardiac and vascular issues. His area of expertise includes taking care of patients with chest pain, palpitations, shortness of breath, leg pain, and episodes of syncope, which is when the patient loses consciousness. He is also especially passionate about educating the community on the importance of health equity and how focusing on those most in need can help bend the cost care within cardiovascular disease. Next to DeChane. DeChane Dorsey is executive director of AdvaMed et al., the division within AdvaMed dedicated to the needs of smaller medical technology manufacturers. The vision of AdvaMed et al. Is to be the leader in advancing medical technology by bolstering the industry's emerging and early growth enterprises, the drivers of disruptive innovation, job creation, and economic expansion. This division is committed to ensuring the voice of small pioneering and entrepreneurial companies is always heard by policymakers. And she also leads AdvaMed's health equity and women's health equity work streams. And now to Joy. Joy Spencer-Smith is currently living her best life in Chicago. At age 77, she noticed chest pain and shortness of breath, and her echocardiogram showed severe aortic stenosis. Her cardiologist advised her it was time to replace her valve and told her about a clinical trial for TAVR in low-risk surgical patients. Today, she uses her voice to share her story and is a strong advocate for TAVR and heart valve disease awareness. So again, welcome to our three panelists. So let's jump in, and we'll get the conversation started with my colleague, DeChane. So DeChane, can you provide us with an overview of AdvaMed's principles of health equity and how it led to the development of the Medicare gap analysis? And I believe you're also going to share some summary slides talking about the survey.
Sure. Thank you so much, Dr. Washington, and thank you, everyone who took time out to attend today's call. So if we could pull up the slides, and as you'll see, if we go to the next slide, when we talk about the principles that Dr. Washington mentioned. So in 2020, AdvaMed stood up our health equity work stream, and we decided that we needed some principles to guide that work so that we could really better assess what the needs were, but more importantly, figure out what the role for med device makers were in helping to move the needle on health equity. And so we developed 4 principles which center around 4 core policies related to reduction and elimination of bias, increasing awareness by patients, caregivers, and physicians about the range and types of technologies that are available to treat patients, and making sure, more importantly, that patients and their caregivers are really fully aware of all of the treatment options as they make fully informed healthcare decisions. The third prong centers around access. And as we all know, it's great to have a lot of technologies that are designed to help address health problems and get people optimized health outcomes. However, that is all really dependent upon a patient's ability to access and get those devices for use in their care and treatment. So our access prong centers around ensuring that patients are able to get access to the technologies they need to treat their conditions regardless of insurance status. So whether or not you have private insurance, Medicare, if you're a dual eligible Medicare and Medicaid eligible beneficiary, have an ACA plan or something else, we want to make sure that patients are getting care. And in that same prong, we also work with external stakeholders to address issues of connectivity equity, especially as we move into a realm where more devices are digital devices and AI devices, and we want patients in rural areas as well as those in urban areas who may not have adequate broadband access to be able to utilize those technologies. And then our last prong centers around research. And in that prong, we look at the composition of research, making sure that it's inclusive and representative and diverse, and that also the persons conducting that research are representative and diverse. And so those are the principles that we use to guide our work around health equity. And so if you go to the next slide, we decided that one of the things we need to think about was how, in fact, were patients getting access to the advanced technologies that they need for their care. And so that was the impetus underlying our study design. We wanted to understand if there were gaps in how people were accessing care and technologies and what was driving those gaps in care, if there were demographic issues, if there were socioeconomic factors. And also we want to see if we were able to possibly explain why those gaps in access were happening. And then to figure out if those gaps were in any way explained by issues related to the caregivers and or the environment and community in which the patients live. Next slide, please. So we started off by doing a very broad assessment with our membership who represent medical device makers of all types. And these are some of the services that we originally evaluated as we were narrowing down a window of services to use for this analysis. As you see, this is a rather diverse list, but where we ended up were the top 5 disease states identified in the left-hand column. So you'll see cardiac ablation, angioplasty, valve replacement, mechanical thrombectomy, and thrombolysis. And I should also note that when we decided to do this analysis, we decided that we would use a Medicare claims data approach to base our analysis on. That's primarily because Medicare represents a claims data set where they collect some of these demographic points that we were analyzing, but more importantly, where all of the patients in that claims data set have some type of insurance. They all at least have Medicare, with some of them also having Medicaid and other supplemental insurance. And so next slide, please. We broke the analysis out into 3 parts, with the first phase being an assessment of differences in rates of access. And what we began to note pretty early on was that there were broad patterns of disparity on the basis of race, gender, and dual eligibility. And for those who've been following some of the discussions by policymakers, there's a lot of conversation around how different racially and ethnically diverse patients are accessing care, but also there's a lot of conversation around dual eligible patients. Those patients tend to have lower socioeconomic status and qualify for both Medicare as well as Medicaid, and tend to have very marked differences in their healthcare outcomes within the Medicare population. And then we were also trying to interpret what the magnitude of disparity was. So really adjusting to see if there were other factors that may have been contributing to how patients were faring as the analysis came together. Next slide, please. And so when we looked at the access rates, what we began to notice is that there were definite distinctions in how white patients versus patients from other ethnic minority groups were accessing care. And so the analysis was broken out into white versus Black patients, and then white versus other patients, which includes patients of Latino descent, Asian descent, and any indigenous patients that may have been picked up in the analysis. So that's a very hard population to pull data from in the Medicare data that was used. And we used claims years 2018 and 19, primarily because we started this analysis in 22. And we wanted to eliminate the COVID data just because rates of access to care during COVID were so different than traditional rates of access. We didn't want the data to be skewed. And so what we began to identify very early on, as you will see from these stats on cardiac ablation, angioplasty, and TAVR, is that, that the rates of seeking accessing care generally across the general population of patients that had codes that suggested they had the condition was different. Once you got into the indicated population, which was adjusted for patients who actually had been diagnosed and were seeking treatment, you saw a decrease in the rates of difference in access, but you still saw a different rate of access for these more innovative technologies. And so if we could move to the next slide, please. And that talks about phase 2, which was where we went into the literature to see if we were able to use peer-reviewed literature findings to create some more color and context around what we were seeing bear out in the data. And so what we gleaned from the literature were some of the things that are indicated on this slide, that of course treatment guidelines are shaped by clinical trial evidence, and clinical trials generally are not as representative as they should be of all the patient populations, including Black patients. So that may be a factor. We also saw that there were some differences in treatment patterns among Black patients and female patients. And this, in fact, could be influenced by the way that these patients experience care, back to my earlier point about bias in our principles, and how they present with symptomology and how their symptoms are heard and listened to by medical doctors and people at hospitals and other care providers when they present for care. Then, of course, there are differences in access that are driven by the community in which patients live. So access to specialists, access to hospitals that might be higher care level hospitals that have the specialists on staff or the infrastructure to provide some of these services, where patients are seeking services. Are they seeking services in an emergency room environment versus having an ongoing relationship with a primary care provider that then directs them for treatment and care by a specialist, and then they have a much better followed disease progression and treatment program. There is some evidence of implicit bias, again, going back to that first principle I mentioned. And then there's other factors in terms of patient information about their condition and whether or not they are recognizing their condition and when they are seeking care once those symptoms are in fact recognized. And then lastly, we talk a little bit about geographic accessibility, so urban versus rural patients, and how your locality and proximity to care, either at the specialist level or even your ability to receive care at a hospital that might have some of these higher level technologies in place, impacts your outcomes. So we could go to the next slide, please. And so we did a regression analysis, and what that regression analysis showed was that regardless of where patients were actually seeking care, so this means whether these patients were urban patients or rural patients, we still saw distinct differences in how Black patients versus white patients were accessing and receiving this care. We note that if you were in a rural environment, the rates of access by Black patients to TAVR versus the rates for white patients who are accessing TAVR, and I'll use that as the example, even though the overall rates of access were reduced from patients who were in a more urban environment, you still saw less access to TAVR by Black patients in that rural environment than by white patients. And then across the 5 interventions, as Dr. Washington mentioned at the top of this call, we did see that there was a distinction between Black and white beneficiary access of 40%, that dual eligible beneficiaries were consistently less likely to receive interventions, and that geography was not the driving factor. And so if we could go to the next slide, please. And this again is just showing the utilization differences by race and dual eligibility, and pretty much bears out what I mentioned in the last slide in terms of what those differences are across the 5 disease states that we focused on, and how those differences play out for Black patients versus white patients, and dual eligible patients versus regular Medicare recipients. So you see the distinctions there. And so just to wrap up here, in conclusion, if you go to the next slide, sorry. What we see is that the disparities in utilization of the advanced interventions is real and significant. And one of the things that we think about on the AdvaMed side is we work with our members to figure out how to turn the tide and reduce these disparities is clinical evidence and clinical trials and how data is being generated, but also continuing to educate physicians and clinicians and patients and their caregivers as well about their disease state, and about like the real need to make sure patients are being presented with the full range of technologies that are able to accommodate their conditions, but also patients being able to recognize the symptoms so that they're presenting for care earlier in the process. And then lastly, making sure that there is specialty care and continuity of care. So improving the environment and the services that are available to patients across the range of hospitals. So when we think about disproportionate share facilities, we want them to be able to accommodate patients, as well as some of our facilities that are large academic medical institutions, to ensure that patients are getting the care they need. And so that's the 3-part analysis. I would note that for anyone on this call interested in reading the papers in detail, if you go to AdvaMed's website, advamed.org, do a search for health equity, you can go on the health equity page, pull up our principles, and you can pull up all 3 papers to peruse at your leisure. So thank you, Dr. Washington.
Thank you. I really appreciate you giving that overview. I think that gives our audience a good sense of what the 3 phases of the report entailed. So we'll turn our next question to Dr. Horne. So Dr. Horne, based on AdvaMed's report, 4.1% of white non-dual beneficiaries were identified with aortic stenosis, compared to 2% of Black non-duals and 1.8% of those in the other race category. Can you speak to why addressing these disparities is so important from a clinical perspective, and what impact do delays or lack of access to TAVR have on the affected patients?
So thank you for having me. Obviously, it's a very well done study. I guess answer your questions directly first, and then if there's time at the end, maybe I'll share a couple of other thoughts. So it's been delineated for a long time. Brunwald and Ross, there's a famous curve as it pertains to aortic stenosis, okay? The symptoms of aortic stenosis happen to be chest pain, and chest pain, which is we consider angina, syncope, which can be passing out, or heart failure. And so what we know is that once you have severe symptomatic aortic stenosis, you have a 50% mortality at 2 years. So said another way, I don't know who all the audience is today, but I'd like to keep things very plain so that, the goal is to be able to communicate with our end user. So that means if you don't have anything done, you have a 50% chance of dying in 2 years. So I think the clinical impact is real. And so to your earlier point, if you aren't diagnosed with this severe symptomatic aortic stenosis because in many communities, when we get to be older, my grandfather was an AME minister, and he used to always say 40. So a lot of times people, if in the Black community in particular, would say, well, if I've lived 70 years, then, that's been my time on this earth. But we know that the fastest growing population in the United States are people 85 years of age and older. And so what can happen is when we get to be greater than 70 and we start to slow down, have decreased energy, increased fatigue, more shortness of breath, it's not atypical for patients to say, well, I'm just slowing down because I'm getting older. And so that's really important because I talked about this 2-year 50% mortality, but let's say you're not getting diagnosed with it until a year and a half in because you didn't think that it was something that needed to be addressed prior to then. So that even narrows the scope, right? And so there's a real clinical impact. I mean, it's a clinical impact on families. So, I'm lucky enough where my father is 85 years of age, and he's integral to the rearing of our 2 kids, my wife and my 2 kids. And there's some really interesting economic data because what happens when we look at, so between 26 and 29% of people in the United States have aortic stenosis. For presumably everybody on this call knows what aortic stenosis is, but just to be complete, so the heart has a left and a right side, top and a bottom, separated into 4 chambers by valves. So the aortic valve is the valve that lets blood leave the main pumping chamber of the heart and go to your brain and all your vital organs. So if that valve doesn't open, then blood can't go to your brain. It backs up, goes to your lungs, goes to your stomach, goes to your legs, causes you shortness of breath. You can't sleep with multiple pillows, right? And so, like I said, between 26 to 29% of people 65 years of age and older has aortic stenosis. Between 1 and 8, 1 out of every 8 people 75 years of age and older has moderate to severe aortic stenosis. And I just told you that the fastest growing population in the United States are people 85 years of age and older. So it's really important that we start to identify this particular disease state. And I think as a medical community, as a physician, I think we've done a suboptimal job in terms of communicating effectively with our patients about this particular disease state. If people have chest pain, the first thing they think about is, am I having a heart attack? If they have slurred speech or some type of strength asymmetry, they think I'm having a stroke. But if you're, like I just told you, those numbers, if you're 75 years of age and you're having chest pain, I would think about your aortic valve as well. So the the real clinical impact is incredible. And then also the cost to the healthcare system is incredible, right? Because these people are going into the emergency rooms with congestive heart failure. And, it's really disrupting people's lives. So, I think it's incredibly important that we be more diligent about this. In terms of, I believe the part of your question was, why is it disproportionately not getting through to multiple communities? And I just want to reference the first sentence in the executive summary. It says racial and ethnic healthcare disparities in access to advanced interventions have persisted for decades in U.S. healthcare. So that's the part that's frustrating. I've been a practicing interventional cardiologist for more than 10 years myself. Unfortunately, a lot of this data isn't new. So the question really is, what are we going to do about it? And we've been, like you said, in the first sentence of this executive summary, it states that this has been going on for decades. And access to pacemaker care, and access to angioplasty. Now, TAVR just celebrated. The first TAVR was done in France by Alain Cribier in 2001. 23 years. If you look at the transcatheter valve therapeutics, database, it shows that only 3.8% of African Americans in the United States get access to this particular care. And I just told you that there's a 50% 2-year mortality. So the question is, where is our value system? What is important to us? And I hope that interactions and conversations such as this will hopefully continue to put topics like this at the top of the radar. I know there was a CMS Health Equity Conference that just concluded. I think that these are the type of topics that should have been integrated into those discussions, but at least we are using our platform for how we can.
Thank you, Dr. Horne. Those are very sombering statistics that you stated. So we definitely have a lot of work to do, and I sense, and I think we share some of your frustration that we know these issues have been going on for a while. So hopefully we can get to solutions to start addressing the issue. So Joy, I'll turn next to you. So as a patient advocate, can you share with us your journey with valve disease? And in your opinion, what are some of the barriers that you see in preventing patients from getting access to the TAVR procedure?
Oh my goodness. All right. Well, I'm one of those patients. I was working. I never truly experienced any of those symptoms that most cardiologists talk about. I did not have shortness of breath. I did not have a pain in my chest. I was at the time when I was, my mom had aortic stenosis, and she was at the age, she died at 86, but her illnesses prevented her from having open heart surgery. And so she just quietly one day just went to sleep. I think the thing that is most important is to realize that most people do not, and I'm including myself, I'm not saying that I maybe did not have those symptoms, but I never recognized them or never paid attention. I loved what I was doing. I enjoyed my job. I worked for Amtrak. I traveled over the country. I had large responsibility, and I was having a ball doing that. That could make one not pay attention to yourself. All right. Other people, the bottom line, when you talk about heart conditions, I will soon, God willing, be 83 years old. All right. So at most people, it's the fear of dying or accepting the fact that fate's fate. That's my fate. That's what's going to happen. So I don't need to deal with it. I think we need to look at other issues other than the typical excuses or typical reasons that I hear, that we don't listen, we don't get involved, we don't ask the right questions. If that makes sense to you. The bottom line is, when you have so much responsibility, a parent raising, a single parent raising the children, barely making it food and paying rent and all of that, one will not look at one's health, because the issue is getting through, getting by. Are we addressing those issues? I find more and more of the African American community and the people that I deal with, we're not trusting each other as we used to. There's less and less of us trusting each other. Why is that? Are we not really communicating the way we should? Are we feeling that do our people feel that we really don't care the way we should care? I think the answers are very simple and very basic, and it's right in front of us, but we're not looking at it because we're looking for something else. And the answer to me is right in front of us. The first thing is to combat my fear. And that's what my cardiologist did. The first thing is to let me know, if you tell me that I'm going to die in 2 years, you have not inspired me to do anything. That's what I have to do, then that's what it's going to be. Well, that means I got 2 years to get things together and so on. That's how some people look at it. If you think you're only supposed to live to 70 years old and you got your mind fixed on that, it's not much you can do with that. But when my doctor said, okay, Joy, every time I went to the doctor, he would tell me what my progressions of my aortic status was. When I first got the sign and paid attention, I had retired. I retired at, 72, 73 years old, 77, 78 years old when I retired. I was doing Meals on Wheels. I was doing a volunteer work doing Meals on Wheels. I had just delivered my meals, and I had a hot burning sensation down the middle of my chest. The first time I ever had anything like that to sort of stop me in my tracks. I sat in my car, took a deep breath, said, what the heck is this? I knew it wasn't heartburn or anything like that. I got over it, went on about my business, paid no attention to it, which is typical. All right, typical. A week later, I'm walking to get my hair cut to the barber, and that hot pain comes down the middle of my chest again. Now, mind you, just 6 months prior, I'd had my heart examined, which I was doing every 6 months, doing the things that I thought I was supposed to do. I went to the doctor, and he says, okay, he used the faucet to show me exactly what was happening, how the blood was going through. And he said, Joy, it's time now for us to look at having surgery. I looked at that as having open heart surgery and something else that was going to stop me from doing what I wanted to do. Oh my God, I got to go through all that, blah, 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 blah. I just went on. And then he is the one that recommended, you like helping people? Would you be interested in participating in the trial? That's another thing that we don't seem to be so eager to do. And I think we could get our people to get more involved if we find the right words, the right technique in order to gather people in. And so I said, yes, I love helping people. That was what encouraged me, because you said I could help someone. And that's how I got involved and knew about TAVR. And while I've been so passionate about it ever since, because I think it is something that people should know more about. And it's not just people in poor neighborhoods or uneducated. I know too many of my coworkers and professional people that have just as silly about their health as anybody else. So I hope I've answered that question for you. I can go on, so you have to pull me back because I can run off.
No, but thank you very much for sharing your story. We can definitely see your passion, and we do have a question for you that we'll hopefully get to in the Q&A. But yeah, no, thank you very much. And there was just so much to unpack in just that one story. But we'll move on to the next question. So we'll turn it back to DeChane. So DeChane, can you tell us what role AdvaMed has been playing in addressing some of the issues? And then after that, Dr. Horne, if you can answer the same question on behalf of the Association of Black Cardiologists. So we'll start with DeChane.
Sure. So I think, as Dr. Horne has stated, as Joy kind of brought out the need for in her comments, there is certainly a lot that remains to be done in terms of advancing these issues and getting the policymakers and the regulators to really work to create a system that is more conducive to patients getting the access to the technologies and the healthcare that they deserve and need. And so AdvaMed is a medical device trade association, which means a lot of our work really focuses in the advocacy and policy making space. And so one of the things that we've been doing, aside from generating these papers, which, to Dr. Horne's point, CMS did complete a health equity conference yesterday, and I stalked the CMS team like world's worst stalker and put the paper literally in everybody's hand and hope to have meetings with them, because the reality is we really need to have some conversations around this data. What we know and understand is that CMS is collecting this data routinely from millions of beneficiaries, but what are they doing with the data, and how are they combing through the data to see if there are policy changes that can be made to better ensure patients are getting what they need. And so we really work through our members at AdvaMed to advance those types of issues and are developing recommendations to present to CMS on this particular issue regarding the paper, but also have been working with folks at FDA and other agencies, as well as people on the Hill, to support legislation that helps move the needle on health equity, legislation around clinical trial equity, legislation around access to care in terms of how things are covered and paid. And that is something that remains very high on the radar for AdvaMed. I would note that I don't know Joy's doctor, but Joy had the benefit of having a great doctor monitoring and caring for her. I am a 53-year-old Black woman. I have never been asked about clinical trial participation. I have sat in my physician's office and read signs and placards about clinical trials that are being offered for conditions that I have, and have never had that offer extended. And so I think it's really important, to Joy's point, that, people are getting that information, and that information is being afforded to patients for them to either accept or decline the offer for clinical research, but also accept or decline the offer for what type of innovation they want to have deployed in their care. So I will stop there and turn it to Dr. Horne.
Yeah, so because I also just want to express my gratitude for our patient being on this call today. Your voice is the voice really that resonates the most, and I mean that sincerely.
Thank you,
I mean that sincerely. This is I'm older than I look. You can't see my gray hairs on the screen here, but I've been fighting on this topic for a long time. So it was in 2014 when the TVT registry that I referred to earlier first reported its 5-year data, which was real world data, not randomized control data, real world data showing that only 3.8% of African Americans got get access to TAVR. And so the reason why I keep on going back to 2014 is because the Association of Black Cardiologists, which is just celebrated our 50-year anniversary, advocating for health equity within the cardiovascular space, including stroke. You know, it was Isilma Fergus, who's at Mount Sinai, and Dr. Robert Gillespie was the chairperson. Dr. Fergus was the president. I brought this topic to their attention, and that was the establishment of the Structural Heart Task Force for the Association of Black Cardiologists. The question specifically was, what are organizations doing to combat this? So we hosted a roundtable, and we developed the first consensus white paper where we recommended specifically what industry needed to do better, what physicians needed to do better, what people in government, CMS in particular, needed to do better. We reached out to clergy. We reached out to people within the public policy space, and we just now did the second roundtable. It's been 2 years from now, and published another paper on this topic. Some of the people on this call were a part of that. And so we continue to be vociferous in our advocacy and comprehensive recommendations with regards to how to do this. The payers are important because they're the ones that we talk about, these dual eligible patients. And, we think that, so this again is a Medicare patient population, people 65 years of age and older, but people look at secondary insurers and, questions regarding payment come into play. And the reality is, and you're right, ma'am, a lot of this isn't just a socioeconomic issue, but it does come into play. Economic status comes into play, the geography comes into play. For instance, I practiced in a rural area of Texas once where you had to be 2 hours away just to get a cardiac catheterization and a stent, let alone a TAVR. Right? So those things do matter. And so, the Association of Black Cardiologists, in addition to this advocacy, we do Spirit of the Heart events where we go out into the community. I do a lot of these, now, board member, of Heart Valve Voice. And that's how this is but this is all volunteerism for us, right? As a physician of color, this is what I think is my responsibility. And so, I'm now the director of structural heart for Summit Health. And, we obviously have a diverse patient population, but, I'm tell you what, there's a lot of people that aren't getting access to this therapy who should be. And in terms of why I told you that you were the most important on the phone, I'm going to tell you this. I have another example. So we just published, the AVITA trial. So this is a trial that's looking at getting in touch with the patients and giving them tools where we can understand what's important to them, right? Because too many times, historically, there's been this patriarchy and matriarchy in medicine where it's like, I'm the doctor, you do what I say. Like, how am I going to come into your living room and tell you what's important to you, right? So the most important thing is to understand what your values and beliefs are and then meet you there. I can give you the medical information, but again, like you said, some people, if they decided they're 7 that's all they're supposed to be, or if they think they got 2 years to live and they get my affairs in order, I got to meet you where you are, right? And so that's what we need. And, a big part of this is implicit bias. Doctors got to do better. You got to look themselves in the mirror. Most doctors, I think their heart's in the right place, but you got to look yourself in the mirror sometimes and say, well, what can I do better? Right? Doesn't mean that you're a bad person if you have implicit bias. It's just that you just don't know what you don't know. Right?
That's right.
You don't know what you don't know. And so I'm gonna try to keep on going and keep advocating. But I'm gonna tell you what, we got a lot of work to do, and I really hope that we're gonna need to put you on the road and take you around so you can talk to some of these doctors with us. We need your help. You're inspiring me.
All right, my darling. Okay.
Thank you, DeChane and Dr. Horne, for those remarks. Yes, it's obvious that there's a lot of advocacy work being done, and that we still have a long way to go. And I agree, Joy, your voice and your story, we need to, I think one thing that, I feel as we continue to have these conversations is that we do need to think of different approaches, because what we are doing is not having the impact that we want. And so we can try and think of some other approaches. So Joy, that brings me back to you. So just thinking back to the report, what we've been talking about, from your perspective as the patient, how can we take these findings and, have these conversations with clinicians, policymakers, stakeholders, from your vantage point as a patient or a patient advocate, what do you recommend or suggest for moving forward?
Well, I think I'm an ex-school teacher. And I think that sometimes we, just like Dr. Horne says, when you got to bring it to my level. I remember one time a young Jewish teacher told me that, oh, Joy, you shouldn't talk to the student like that. You got to bring them up to your level. I never will forget that. And I said, in order for me to bring them up to my level, I got to get down to their level to get them up. I think sometimes we got to say, get a cup of coffee, young man, come on in here and let me talk to you. It's got to be as basic. Let's just go back to basic, simple expanding. We don't need as many people as we think we need to get something done. If you look at history, it only starts with one or two, a handful of people to turn the tide. I believe in that strongly. You got to get the right mix, the right kind of people, and the right passion. If you no longer have the passion to help and reach down and help, because that's the reason you wanted to be a doctor in the first place, was to help someone. All right. If you don't have that, leave them alone, go past it. I think we're looking for policymakers and making things law and making that right. That ain't gonna get it. It's got to come from the heart and soul, and that's when you're going to see getting things done. Get that loud talker in the community, that one that's running off at the mouth all the time. That's the one we need to get. Let's educate you and tell you what is really wrong. Don't use scare tactics, because you're going to die one way or the other. That's inevitable. The thing is, how do you live well? How do you live well so you can take care of your daughter? You can take care of your son. You can see your children do or materialize your dreams, right? And I think that's the best way to go. Go back and peel back that lemon or the orange or whatever it is and say, what are we missing? Because everything that Dr. Horne is saying, we're doing. Churches are doing the best they can, but to me, they can do better. What are big organizations, Heart Valve? We're doing things, but you're still not reaching the people you want to reach. So what do I have to do? So if I've got to get off and put on some sneakers and put on my rap clothes in order to get down and talk to you, then baby, that's what we're going to have to do. Because I got something to tell you and you're going to listen to me. And if I can be of any help to any one of you, just pick up the phone and call me. I'll be there.
No, thank you. We appreciate that. So I hear you saying we have to let patients use their voice and find those voices who can speak in the community and reach people who otherwise we're just somehow still missing in all our good intentioned efforts.
Yes.
And Dr.
Yes.
Washington, I would just add on to a little bit of what Joy said about that. I mean, I think that's a huge part of what we've been trying to drive home when we talk to people about health equity, right? Because to me, I guess having lived this life experience, it's pretty common sense to me that if I am a patient, I want to just know what my options are. I want to know what all of my options are. I don't want to know what you think is the option that I'm going to pick, or what you think the option is that I can afford, or what you think the option is that's going to not freak me out, because people like me get freaked out by the medical system. I just want to know what my options are so that I can choose wisely. And that doesn't necessarily mean that I will select the option that is the most sophisticated, or that might even get me more longevity. Maybe I'm looking for quality versus longevity, but I still deserve, and every patient deserves, to have that conversation and that relationship with their care providers. And then on the flip side, they deserve to live in a system where if it's something that is available that they've decided to get that's going to improve their health outcomes, there should be a mechanism for them to get access to that product.
Right. Amen.
Thank you, DeChane. I'll turn it back to you, Dr. Horne. Just wanted to see if there are any other practice level changes. I know you've touched on it already, but as the clinician on the call, do you have any other practice level changes that you would recommend or put forth that we could implement to start making more progress?
Yeah, so no, I think it's a great question. And this has been a very powerful conversation. I mean, what everybody said has really resonated with me. You know, we mentioned clinical trials being at a lot of, quaternary care academic facilities, but it's also important to note, and, I was privileged to go to a lot of those institutions. But, there's a lot of physicians that are practicing outside of academic medicine, right?
Mhm.
Talk about clinical practice, and, I practice 20 minutes from Newark, New Jersey. Okay. And so what's important is that within aortic stenosis, I think that in terms of practice, we're talking about system changes that can happen. You talk about, sort of on the ground level practice changes that can happen system wide. I think so. Hospitals, so for instance, right, Medicare, so beneficiaries, let's say if you come into the hospital with quote unquote congestive heart failure, we know for a fact you cannot be discharged out of the hospital unless you're on particular medications, right? You got to be on a beta blocker, an ARNI or an ARB or an ACE inhibitor. I make these fancy terms, but you literally can't be discharged from the hospital. So the question is, if you're 75 years of age and you come in with chest pain and shortness of breath, should we make sure that you have an echo done before you leave the hospital, right? So those are ways system-wide that we start to triage, right? So you think about, women, you older than 45, you get a mammography. If you're a man, you get a prostate exam, right? As we're living longer, these are disease states that we know we have. So on a practical level, I think those are system-wide changes that we need to really be more attentive to. On a ground level, it's really complicated, right? Because people used to say, well, do Black people just have less aortic stenosis than their white counterparts, right? But then if you looked at long-term care facilities, right, people, because we know that for a lot of different reasons, a lot of Black people don't access the healthcare system, don't have primary care providers. But if you look at long-term care facilities, people that are in a long-term care facility for whatever reason, and you do echocardiograms, you see that there's equipoise. So Black folks have just as much aortic stenosis as white folks. So that means on the practice level, the ground level, we know there's an underdiagnosis, there's under treatment. I've published on this, over around 8 to 10 years ago now, in terms of this is also not just in TAVR space, but in the aortic valve surgical space as well, right? So we definitely need to, on a practice level, make some of those changes. But I think, again, our patient here is just incredible. I call you Miss Joy. I know your last name, ma'am. I don't want to be disrespectful.
Smith.
Okay. But, I think you're right. We just gotta, we gotta roll up our sleeves. And I think the point you're making just incredible, because, they talk about in terms of clinical trial participation of Black folks, right? Now that's complicated, right? Because a lot of people in your generation lived through Tuskegee, and there's a deficit there, right? And so it takes some work there, and you're gonna have to roll up your sleeves and treat folks the way they need to be treated. Ain't nothing about there's no education deficit. Like you said, you were a teacher. Right. It's just, if I'm smart enough to know that I don't trust you, right? Right. We said I might have been born at night, but not last night. And so we got a lot of work to do. And I'm still, I'm excited that, you really have invigorated me, because, like you said, you're the person that I keep on trying to tell people, this is our patient right here, right? She's brilliant, right? And she's telling you everything you need to do. We just got to get the people that make the decisions, to be honest, to really get on board, and they have to care. Like you said, do they care?
Yes.
But there's even an economic piece to it, right? Yes. Because if you get these people access to this therapy, they're not going to continue to access the emergency room with heart failure exacerbations, contribute more to society, right? So there's an economic argument to actually penetrating this market, if you want to look at it that way, more as well. But just do right by people. You can do right and do good.
That's right. Amen.
It's a great way to close. Do right and do good. So I'd like to thank you all for your comments. So we're going to transition now to some Q&A. So I'm looking in the Q&A, and if you have any questions for any of our panelists, please do feel free to go ahead and put them in there. So I'll start. The first one is to you, Joy. It's from Jody. She thanks you for sharing your story. And she wants to know, how did you decide on TAVR and get the information that you needed to make that choice?
Okay, as I said, after 41 years of working with the railroad, and then of course a total of maybe over 50, because with Board of Education in New York was another thing, I wanted to give back and volunteer. So that's why I went to doing Meals on Wheels. My doctor was Dr. Das Gupta from India, who was my heart doctor at Northwestern Hospital. And of course, as I said, my mom had aortic stenosis, and here I'm the oldest of two sisters, and I had it. And that's another thing. Oh, well, it goes in my family. We all have it. We have a tendency to say, okay, that's okay. My mom had it. I got it. It's okay. All I wanted to do was make sure you leave me alone, that I could go and do what I wanted to do. Very stubborn person I am. So he was the one who every 6 months when I have my test would insist that I sit there, and he would go through everything. And how he really trained me about my aortic was to use the water fountain to show me how the blood was going through. When he said, there is a trial going on, but he used the word, you like helping people. I said, yes. He says, well, we need your help. And that's how I got involved with TAVR. Had no idea about that before, nothing at all. He sent me to the Institute, the Bloom Institute at Northwestern. I sat there and talked to the doctors and the nurses about what TAVR would mean. And at that time in 2019, was 2018, and he said we had to get permission from FDA to approve me to have the procedure. We didn't know when we were going to get that, but I had to be ready to go the moment FDA said okay. I said fine. Went on about my business, and my sisters and I, we prayed about it, and if I could be of some help, that was my inspiration, that would I help somebody else. All right. So in February of 2019, FDA said yes. On my doctor's birthday, February 13th, I had the procedure. And I went through all of the tests and things that you had to go through. I had the procedure. That was on a Wednesday. On Friday, I was home. And I've been raising sand ever since so far. All right, I've got to get my checkup every year. I just had my checkup, and want to be more involved and encouraging others that thought the way I was thinking and behaved sort of way, that I could sit down and really talk to you. And I have encouraged only 3 people around me so far that had to have this procedure, that was so glad I talked to them about it, and they all doing well. So did I get off a train of thought here? I get so carried away here.
No, that was a great answer. So it was about how you got to your decision to receive the TAVR. Mm-hmm.
It was an easy decision. My mom used to say to me every day, she said to her girls, walk with the king, be a blessing to someone, and do good work. I live by that. And of course, it hasn't been easy, because being a blessing to some of these folks is real hard. Right. Trying to be to someone.
I actually wanted to follow up on something you were saying earlier about, speaking to others. So I'm just curious. So as you talk to your network, your community, your family and friends about your experience, do you find that many of them feel similar to you and that they would be happy to join a clinical trial if only they were asked? Because that's something that we've been hearing a lot, is that a lot of people, like to DeShawn's point earlier, they're willing to be in clinical trials, but as we know, our numbers are not, we're not represented well in clinical trials, and a lot of the times because we're just simply not asked to be in one.
Number one, Dr. Horne hit it on the head. The key thing is, are you asked? If I had not been asked by my doctor, and what control as a patient did I have over my doctor to discuss anything like that with me? I would not know about that. I would not even think about that. So that has to come from the doctor, and that has to be another way that we try to get the communication out. Now, when I sit down and I talk to someone about participating in a clinical trial, Dr. Horne is also right. I am from that Tuskegee generation, so to speak, where everyone has that fear about not trusting. That's a key element, that trust. And sometimes you can get it, and sometimes you can't. You're not going to get everybody to trust you. If you get one person out of 20, you're successful. That's the key. You're successful, because that one person you get is going to tell the other person. Get one person to communicate with it. And so once I sit down and I talk to a person, it depends on who I'm speaking to will determine how I'm going to address you.
Mhm.
And one-on-one.
Making it personal.
That's
Mhm.
right. I don't have any problem. If you want to go left, I'll go left with you. If you want to go around the bush, I'll go around the bush with you. Whatever it takes for me to get you to listen and do, that's what I'm going to do. And then, of
Got
course, you have to be willing to give the time, my dear. That's the key. You have to be willing to give the time. And you can't have on your mind, I want to make you do this. I want to get the numbers right. You can't have that on your mind. Because the numbers will come. You know, my dad used to say, find a job that you enjoy doing, that you love going to. Don't worry about making the money. The money will come. My dad was right.
Mhm.
And that's how I feel
Yeah.
about it. Yeah, communicate. Find that person you can talk to. And if you could change one person to understand, that one person will tell 2 or 3 other people.
Right. So word of mouth, definitely. Moving on to our next question. This is just logistical. So Dr. Horne, we have a question. Would you be willing to share the ABC white paper that you referenced earlier that had the recommendations to address health disparities?
Absolutely. Carissa can share that in a chat, or we can make sure that you get that information.
Good.
But I've already made a decision. I'm not following Miss Smith no more. So I've said everything. No need to be said.
No, I understand. I wouldn't want to follow her either. So we're actually at the conclusion. So again, just thank you to all 3 of our panelists, Joy, DeChane, Dr. Horne. Everyone has been phenomenal. And I just thank you so much for sharing your perspective. If we just want to do a quick round the table, 30-second, parting thoughts, recommendations for going forward, just, one thing that you want people to take away. And so we'll start with, no one wants to follow Joy. So we'll start with you, DeChane.
Sure. So I would just say in concluding, and it's been an honor to be on this panel with Ms. Smith and Dr. Horne. Both of your comments have been tremendous and invaluable to this conversation. And I would say, we really need to just keep pushing to make sure that patients are informed. I think that when patients are informed, which means that caregivers and the industry and everyone is doing their best in getting that information education out there, that even the patients will start bringing the questions to the doctors, because that's another way that we sometimes will get the information we need. So as Joy mentioned in her conversations with her peers, when she tells them about TAVR, that means she's empowered them to go to their doctor and ask about it if they haven't been informed before. And so this each one teach one mentality is going to be huge, but we really need to make sure that we are well informed as a patient and as a developer group and as a care provider group.
Thank you. Dr. Horne?
Yeah, so, Gary Gibbons is the head of NHLBI, and it's about 5 years ago. So he has resources by which he can figure out studies to fund. And he said, he's really interested in action-oriented research initiatives, right? I think that, again, going back to what I opened my comments with, is that these disparities within technology and even just basic management of things such as blood pressure within Black and brown communities has been going on for decades. So I need, we know the problem exists. The question is, what are we actually going to do about it? And there's these governmental agencies, industry, they have a lot of resources. Put your money where your mouth is. If this really matters to you, and that the societies are starting to be more vocal, but, Associated Black Cardiologists, again, our founder, Richard Allen Williams, and under the stewardship of our CEO, Cassandra McCullough, we're working as hard as we can. And we're happy that people now, health equity, is a catchphrase now, but let's put some resources behind it. Put some money where your mouth is. Let's really engage organizations such as us and people like Ms. Smith to really get into the communities and do the work that needs to get done. Because this is, again, and I'm not to make light of this, I keep on going back to this, because this is a deadly disease state, right? And, I'm not talking about just quantity of life, but to your point, Ms. Smith, quality of life. The point is, even if you only got 2 years, let's get that good quality of life in those 2 years, not you having to be stuck in your chair. So hopefully we'll, focus, put some more resources on it and make some progress. Thank you for including me today. Happy to be here, and look forward to working with you guys moving forward.
Thank you. And Joy, your final words, please.
Well, I thank you very much for inviting me and allowing me to express my comments and feelings about this. I wish you all the very, very best. You're in my prayers, and if I give any assistance to anyone, all you got to do is just call me 24/7. You don't have to have a special day or special time. Just pick up the phone and say, Joe, we need you to do such and such a thing. And I'll be there to assist whatever I can. Thank you so much. I am just absolutely honored to be a part of this discussion today.
Thank you. And thank you all again. And so thank you to our panelists. Thank you to Heart Valve Voice for this forum. And we look forward to continuing this difficult but absolutely critical work. So thank you. And this concludes our webinar for today.
God bless.
Thank you all. Bye.
Thank you.